Arik Zaider, the Valley Institute for Rheumatology and Autoimmune Disease. And in rheumatology, we deal with a wide range of conditions, everything from musculoskeletal pain to autoimmune conditions. But we're also very concerned about bone health. And that's because, of course, bones are part of arthritis and of musculoskeletal health. But also it's often seen alongside our conditions and alongside the treatments for our conditions. So osteoporosis is something that we are very interested in, that we actively manage and try to help. So welcome and thank you for coming to the talk. So just as a brief outline, we're going to discuss what osteoporosis is. What is the impact of the problem? How prevalent is it? And what are some of its complications as a major public health issue? How do we diagnose it? When do we suspect it? And how do we establish the diagnosis? Once that's done, then we talk about how to manage it. Hang on one second, please. Okay. So what is osteoporosis? Well, osteoporosis, if you look at the components of the word, it means porous bone. In other words, the bone mass that consists of fibers very well and densely stacked together over time can diminish. And this results in a decrease in bone mass, bone quality, and bone density. This causes the bones to be weak and brittle, and therefore more likely to break. And that's the concern with osteoporosis. It's not just that the bone may be thinner, but it's also that it can lead to complications like fracture, and we'll be talking about that. Osteoporosis develops very slowly over the years. It does tend to become more common as we get older. And that's because of physiologic changes that occur in the body, namely the gradual loss of estrogen, and in men, the gradual loss of testosterone. One of the things about osteoporosis is it's asymptomatic. In other words, it's what they call a silent disease. There are other conditions like that. I would say hypertension is another similar condition where you have it, but you may not know that you have it. And by the time it comes to attention, it's often, as we said, in the form of a fracture. By then, it's been around for a long time. I want to distinguish osteoporosis from osteoarthritis. They both have the word osteo in them, but they're very different. Osteoarthritis, of course, is the development of arthritis and is highly symptomatic, unlike osteoporosis. So here's just a depiction. Let's compare a normal bone to osteoporotic bone. On the left, you see that there's a very dense lattice of fibers within the bone. This gives it strength. It also gives it durability and resilience at the same time. This is what allows us to withstand pressure and weight and impact. However, over time with osteoporosis, you see that many of the fibers have disappeared. Now there's a lot of porous space. Porous means whole, and that's why they call it osteoporosis. And this is what it kind of looks like deep inside the bone. Okay, so let's talk about the impact of the problem. It's very, very prevalent. So osteoporosis is estimated to occur in about 10 million Americans. The majority are women, 80% are women. As we get older, the risk of osteoporosis increases. So something to like 20% of women over 50 will have osteoporosis, 30% over 65. If you do the ethnic breakdown, it's more common in white, Asian, and Hispanic women, less common in Black women, but occurs across the board. So again, why are we concerned about osteoporosis? We are concerned because of fractures, of course, So the incidence of fractures is very widespread. It's estimated that about 2 million fractures per year occur due to osteoporosis. They're broken down into all kinds of fractures. The most common are vertebral fractures, which we'll talk about, hip fractures, wrist fractures, and there's some 800,000 additional fractures, which of course can occur in other areas like the ribs, the wrist, or the shoulders. So the lifetime risk for fractures is quite high at this point, based on what we know about osteoporosis and based on how it's treated. And that's why we really want to get it under control. Now, let's also just briefly mention that osteoporosis is not just a women's disease. It can occur in men, as we said, less common in men, but it tends to be overlooked. In the same way that it used to be that heart disease was sometimes overlooked in women because it presented atypically. So it's often the case for men. They're not suspected to have it, and they may actually have it. So they should be included in our recommendations for screening and treatment. And the healthcare costs are quite substantial, as you would imagine, dealing with the problem of osteoporosis and also dealing with complications of osteoporosis. Okay, so that's just an introduction. Now, how do we diagnose osteoporosis? Well, the first thing we want to identify is if the risk factors are there. If we identify risk factors, we can then proceed with testing for osteoporosis. And that's kind of the algorithm. So what are some of the risk factors? So as we said, older age, women over 65 automatically have a certain risk for osteoporosis. Doesn't mean they all have it, but it is a risk factor. Men over 70. Being thin is a risk factor for osteoporosis, particularly less than 127 pounds. In most of our conditions, we want people to lose weight, but in osteoporosis, we don't want to be too thin either. Use of cigarettes, use of alcohol has an association. It's a preventable risk. Any fracture, as we said, we should really have a slogan that says fracture equals osteoporosis and osteoporosis equals fracture. So the presence of fracture is a big risk factor. And there are certain medications, as many of you probably know, that have a particularly high risk of osteoporosis, including steroids. Prednisolone are prime example. There's also a lot of chronic conditions that are associated with osteoporosis, meaning to say, just having this condition, because it's inflammatory, can lead to bone loss. And rheumatoid arthritis is the prime example. So anyway, you see now why rheumatologists are involved with osteoporosis, because we're often involved with steroids and often involved with rheumatoid arthritis. And so this begins our evaluation for it. Okay, so we said that osteoporosis is asymptomatic, and it's true. Most of the time it is. Sometimes you can get a hint just by how you might be changing physically. So I would particularly bring attention to vertebral fractures, what they call compression fractures. They can occur very subtly and very slow over time. And some of the hints are a loss in height. So if you start to lose height over time, that might be a hint that the bones are getting thin. It can also result in a change in posture. So the sort of hunched over posture that you see here is due to the gradual softening of the vertebral bones, which then leads to a malalignment of the spine. So just a brief word about fractures, different fractures are higher in incidence in different age groups. So wrist fractures are more common in younger women. The common scenario for wrist fracture is, I fell against an outstretched arm, and this is how a radial fracture or a Colles fracture often develops. You can see it depicted here in the picture, and you see hints of it in the on the X-ray. It doesn't always need surgery. Sometimes it suffices to put a cast on it, but that's a hint that happens. Now, this just reminds me to say, one of the questions you may have is, well, yeah, I had a fracture, but it was a bad fall. It was a bad hit. So anyone would have fractured. So how do we know when a fracture is due to osteoporosis versus being like a legitimate fracture due to trauma? So, what we define in osteoporosis is something called a fragility fracture. Fragility fracture is defined as a non-traumatic fracture or a fracture that occurred when falling from standing height. So let's say you're just standing and you happen to fall and trip, and then after falling, you develop a fracture. So that by definition is an osteoporotic fracture, because normally, an 18-year-old wouldn't necessarily fracture a wrist or a hip if they fell from a standing height. So when we mean fracture, we don't mean, oh yeah, I had a fracture when I fell off my bike and I was 9. We mean a fragility fracture. Sometimes it's even more subtle than that. Sometimes it can be a stress fracture of the foot, or other things that we'll mention. So this is a hip fracture, common as we mentioned. most commonly occurs in the femoral neck. It's diagnosed by X-ray. Sometimes you need more subtle studies. It can be very, very hard to find. Sometimes you need an MRI or CT scan to find it. And the treatment approaches, it doesn't always need surgery if it's a closed, non-displaced fracture, but sometimes it does need rods and screws or a hip replacement, depending on what the problem is. And here are the vertebral fractures that we're talking about. So just to show you what it looks like, if you look at the far right, you see depiction of X-rays here. You can see it's kind of outlined. This middle vertebral body looks squished. It looks thin like a pancake, and that's called a vertebral compression fracture. Very often, these are diagnosed by accident. So if you happen to get a chest X-ray on someone for another reason, and someone looks at the spine and they say, "Oh, wait, I see a vertebral compression fracture there." Well, as soon as you see that tells you that osteoporosis is present, and you don't even need other signs. Again, most of the time asymptomatic. When it happens after a trauma or injury, coughing, picking something up, you suddenly notice this acute back pain. It can be very painful as well, and again, sometimes presents atypically. Sometimes it can radiate to the abdomen. Okay, so well, now that we identified who's at risk, so who should get tested? So the answer is whoever's at risk should get tested. It's only logical. And it really correlates with a lot of the things we've been talking about. So all women over 65 should get tested for osteoporosis, and that's mandated by Medicare. Men older than 70 as well, but you don't always get coverage for it. But what if you're younger than 65? Should you get tested for osteoporosis? Should you get a DEXA scan, which we'll talk about? Well, the answer is yes, if you have the risk factors that we spoke about, namely history of fracture, chronic conditions, medications that might lead to osteoporosis, low weight, or perhaps excess use of cigarettes or alcohol. I'm just putting this slide on, to tell you that what if you're actually really young and have osteoporosis, meaning, premenopausal, and that happens, we see it, it's not common. But then you really look for an underlying medical condition. There are certain medical conditions that predispose to osteoporosis, a lot of endocrine conditions like thyroid and parathyroid. If you diagnose it and you treat it, you can actually prevent and at times reverse the osteoporosis. So it's important to be aware of these more rare conditions they call it secondary osteoporosis when it's not a normal part of aging. Okay, how do we test for osteoporosis? A lot of this may be familiar to a lot of you. It's called the DEXA scan. DEXA scan stands for dual energy X-ray absorptiometry. It's like an X-ray, essentially. It's really very quick and very benign, and they measure the bone density using this study in the spine, in the hip, and sometimes the forearm. It's used to diagnose osteoporosis. It's also used to monitor osteoporosis and see how we're doing. Are we actually improving things? What does the DEXA tell us? Okay, so the DEXA tells us a lot of things, a lot of information, but perhaps the most important finding is the T-score, something called the T-score. The T-score is a number that really tells you your risk of having osteoporosis. And it does that by comparing your bone density to the bone density of a healthy young adult of the same gender, healthy young woman if you're a woman, healthy young man if you're a man. And the key number is 2.5, or I should say minus 2.5. If your T-score on your DEXA scan is minus 2.5 or less, meaning minus 2.5, minus 3, minus 3.5, something in that direction, that is osteoporosis. That defines it, and then we begin to sort of treat it as such. You'll notice that there's a kind of in-between gray category called osteopenia. Osteopenia is when, the bone density is a bit low, but it's not quite 2.5. It's not quite minus 2.5. It's from minus 1 to minus 2.4. We'll talk about how to deal with that. Well, I just want to say that it's not just about the T-score. So the T-score is useful. You'll see it on the DEXA scan, but what if your T-score is normal or not that bad? Does that mean you're out of the woods? So the answer is it depends, because the other big thing about assessing for osteoporosis are what your risk factors are. Some of the very risk factors that we talked about. If you have one or more multiple risk factors, you may still have osteoporosis even though your T-score is normal. So to account for that and to bring that into the equation so that we're aware of it, we do something called a FRAX. So you learn the T-score number, which you should all know if you or a loved one is getting a DEXA scan. But the FRAX is also a number you should know. It's a calculation based on all your risk factors that pumps out two numbers. It's a bit like blood pressure. Blood pressure has an upper number and a lower number. This also has an upper number and lower number. And you want it to be less than 20/3. 20/3 is the key. If your number is 20/3 or more than that, like 30/5 or 35/8, that's a high risk. That means there's a high risk of osteoporosis, not based on your T-score, but based on all your risk factors. And some of the things we mentioned about weight, having a condition, having fractures, having family history, things like that. So this slide's a little bit complicated, but it kind of makes the point that it's not just the T-score that counts. And I just wanted to demonstrate that, based on what it shows. So first of all, if you look with me at the dotted line, look at the dotted line towards the bottom of the graph, parallel to the x-axis. If you get above this dotted line, which is 3% in the case of hip fractures, you have a very high risk, 10-year risk of hip fracture. So above this dotted line means risk of fracture, okay? Now look at this other graph here in the lower x-axis. It's the T-score, okay? The lower the T-score, the higher the risk of fracture. So let's look at someone who's 80 years old, and that's the very top line. So we have a nice 80-year-old patient. What you see is that at what point does the 80-year-old have a high risk of fracture? At what point does the 80-year-old cross the dotted line? So look, the 80-year-old, which is the top line here, the dark green line, crosses the dotted line at -1.2. Okay, that means the T-score of this person was just -1.2. It wasn't 2.5, it was 1.2. And yet, because of their age, which is a big risk, they suddenly have a very high risk of osteoporosis. Now let's take that, let's flip it on its side and look at the other side. Let's look at the 55-year-old. That's the bottom graph. That's the gray line here, the 55-year-old. Well, at what point does the 55-year-old cross the dotted line and start having a risk of fracture? So you see that's at around 3. So at 2.5, which is what we usually say is osteoporosis, the 55-year-old is not really at such high risk for osteoporosis. But once the 55-year-old gets a T-score of 3, then the risk goes up. So what I'm trying to say with all this complicated demonstration is it's not just about the T-score. It's really about the risk factors. And you have to combine the two to come out with an assessment of what's going on. And each case is different. Again, this is just another graph to show you that as you add on risk factors, some of the ones mentioned here, your 10-year risk of hip fracture will go up. So take that into account. So bottom line, okay, how do you diagnose osteoporosis? Well, step one are the risk factors there. So if you have the risk factors, then you test for it. Once you test for it, you get a DEXA scan, which will give you a T-score and a FRAX score. And then you use that to help you out. So how do you use that to help you out? If the T-score is 2.5 or less, that equals osteoporosis. If the T-score is not quite 2.5, it's not that low, then you bring the FRAX into the picture. And if the FRAX is 20/3, this is the kind of thing we do all the time, or if the FRAX is high enough, that FRAX plus a lower T-score also equal osteoporosis, and you're also concerned about it. And this has implications for treatment, of course. And I just want to make that final point once again, that fracture equals osteoporosis. So you could have a totally normal T-score, you could have a totally normal FRAX, even though that's unlikely. But if you happen to have an unexplained fracture, an atraumatic fragility fracture, you immediately have osteoporosis. And that's all the information we need to know. Okay, so managing osteoporosis. So how do we manage it? Okay. Remember the goal. The goal of osteoporosis is not necessarily to get the best T-score ever. The goal of osteoporosis is really to prevent fractures. That's what we want to do. And if there's been a fracture already, well, we want to prevent that next fracture. Okay, so there's a twofold approach. There's lifestyle and there's pharmacologic, meaning medications. And both are equally important and both have their role. Let's look at lifestyle, okay? How can you control, prevent, manage osteoporosis by adjusting your lifestyle? So the Surgeon General has these recommendations just as a general outline. First is to limit or stop smoking if you can, limit alcohol. Those are preventable risk factors. Take calcium and vitamin D because calcium is really what comprises the bone. Calcium, of course, is what bone is made up of. So if you can really boost your calcium and make sure you have enough, that goes a long way to building bone density and preventing fracture. Vitamin D is also recommended. Why is vitamin D recommended? Because vitamin D leads to absorption of calcium. So the two work hand in hand together. Be physically active. We'll talk about this. Increase exercise. What are we shooting for? We're shooting for maybe about 30 minutes a day if you can. The general recommendation for exercise, by the way, for heart health is either 150 minutes a week of mild to moderate exercise like walking, or 75 minutes a week of vigorous exercise, the gym, elliptical, bicycling, something that makes you sweat. So you can apply the same thing to osteoporosis. Exercise is great. Even if you have osteoporosis, exercise should never be held back as long as it's safe. And you should be shooting for about 30 minutes a day. The last thing I want to mention is kind of obvious, but people sometimes forget about it because they're so focused on medicine, and that's how about preventing the risk of falls. There's things we can do to our environment, our home environment, and otherwise to prevent the risk of falling, and that, of course, goes a long way. Okay, so calcium and vitamin D. The recommendation, I'll just point you to the bottom of the slide, is to take 1,200 milligrams a day of calcium and about 1,000 units of a day of vitamin D. So one way to remember it is, roughly speaking, 1,000 and 1,000, 1,000 and 1,000. You want about 1,000 milligrams of calcium, 1,000 units of vitamin D. By far, the best place to get calcium is in the diet, and calcium is part of dairy, milk, cottage cheese, yogurt. And if you have kind of like a serving, of dairy a day, that already equals 300 milligrams. So let's say you have a cup of yogurt in the morning, that's 300 milligrams. You have a glass of skim milk or something later on, that's another 300 milligrams. And maybe some green leafy vegetables, a cup of kale or broccoli, that'll make another 300 milligrams, and you're done. Then you don't even have to take the tablets, and it's a much better way to get calcium. Vitamin D doesn't so much occur in food, actually. It comes from the sun or from plants. So with the exception of fish, they do say that fish have vitamin D, but we usually have to supplement vitamin D with tablets, and so we do that. And again, it works hand in hand with calcium to increase the absorption and build up the bone. So yeah, I think that if you can be sure to have calcium and vitamin D in this proportion, you're really helping yourself. Some people ask, well, if I'm on Fosamax, I'm already on a medicine for osteoporosis. Do I really need the calcium? So the answer is yes, because think of Fosamax kind of like the glue that keeps the Lego together, that keeps the bone together. But you need like the substance of the Lego. You need the bone, the what comprises the bone, which is the calcium. So you really do need both of them. Another thing I'll mention, by the way, another important reason to take calcium when you're on osteoporosis medicine is because the osteoporosis medicines tend to lower calcium. That's how they work. So to prevent that from happening, you go ahead and supplement with calcium. So very, very important point. Okay, let's talk about exercise. Exercise, as we said, 30 minutes a day. There's 3 things you should be doing. This is probably generally true of anything anywhere. It's not just osteoporosis, but it's particularly helpful for osteoporosis. Bearing weight, putting impact on your bones leads to the generation of bone. So that's why walking or running or anything that involves, carrying your weight, and not just lower extremities, but upper extremities too, like resistance training, will stimulate the bone to get strong. And that's why, by the way, a very interesting phenomenon you may know about is observed that astronauts in space lose bone really quickly. They could be these young, like totally fit 45-year-old guys, but they start losing bone equivalent to someone who's 40 years older than them because they're in space and they're not bearing weight. There isn't the weight on the bone that's needed. So one of the ways they counteract that is by exercising very vigorously when they're in space. Fun facts. So weight bearing, strength training, you want to make your muscles strong so they can support your weight, support your back, and then balance training. That's also crucial, of course, because you want to do what you can to avoid the falls. And let's mention again what we said before about preventing falls. There's a lot of things you can do if you look closely at your house, or let's say a loved one's home, to make sure you're minimizing risk. Rugs are a big one. Make sure the rugs don't slip and you have a backing to avoid slippery floors. put away cords, have good lighting, wear good sturdy shoes that aren't going to slide or slip, make sure your vision's good. These things seem kind of trivial and obvious, but they can go a long way. So look around your environment and try to prevent falls. Well, what happens when lifestyle only goes so far? And you still have osteoporosis and it's not improving the way you want it to. So that's when medicine comes in. And we're really in an exciting time for osteoporosis because over the past 10, 15 years, they've developed numerous medicines that work in very different ways and really can go a long way. So before we talk about medicine, let's again remind ourselves, who should be treated. So the answer is someone who has osteoporosis. Someone who has osteoporosis should be treated with medicine. A lot of people ask, well, can't I try the lifestyle approach first? The answer is you can. It depends on how severe the osteoporosis is, and that is categorized. But you have to monitor it very closely. And if you see you're not getting to where you need to go, you start the treatment. To what extent can you expect an improvement in bone density when you're just doing exercise and the lifestyle recommendations we made, calcium, vitamin D, exercise, and so forth? You can usually improve in some studies the bone density 5 to 10%, which is good, which is not bad, but it's not quite what we want, especially when the osteoporosis is more advanced. So I just wanted to drive home that point. Again, this is who should be treated if you've had a fracture, if your T-score is 2.5, or if it's osteopenia, but high frax, that frax number that we spoke about. So osteoporosis, highly complex process. There are cells that cause the bones to be formed. There are cells that cause the bones to be broken down. There are numerous proteins and molecular mediators that have been identified that stimulate one process and the other, stop one, start the other, start one, stop the other. And with the help of biologic therapies, not too unlike the biologics that we use in RA, they've really been able to target some of these key proteins that lead to osteoporosis and really have wonderful results. So we're lucky to live in an era where you really can treat it actively, prevent it, and make it a lot better. To put it real simply, bone is either formed or bone is broken down, and this is happening constantly. So as you are watching, as you are sitting there, bone is being formed and broken down. It's a constant process. The bones that break down, the cells that break down bones are called osteoclasts, and the cells that make up bone are called osteoblasts, to put it very simply. We use this phenomenon of constantly making, constantly breaking down to come up with our treatment strategy. So what do I mean by that? Well, there's two categories of osteoporosis treatment. The first is the treatments that prevent bone from breaking down. So if you're going to stop bone from breaking down, you're going to strengthen bone density, and prevent fracture. The newer medicines have actually figured out a way to actually make more bone, not just prevent it from going down, but actually building it up and making more. And those are kind of higher level, fancier medicines, and there's a role for them as well. Each of these medicines are sort of, tailored to the patient's particular situation. They all have their specifications, how they're taken, when to stop them, what their possible side effects are, who they're good for, who they're not so good for. And these are the kind of questions that we talk about in our office to try to find the best one for a particular situation. But again, we're talking about preventing bone breakdown, and creating new bone. So the most commonly used medicines to prevent bone breakdown are Fosamax, which you've all heard of, and Prolia, which you've also probably heard of as well. These stop bone from breaking down. How about the buildup medicines, the medicines that cause bone to be built up? So one of them is Forteo or Tymlos that you may have heard of. These are injection medicines. And the newest kid on the block is Evenity. It's called Evenity. This is also a very powerful medicine that builds up bone. Turns out that Evenity actually does both. So Evenity is kind of king of the hill. It's really the one that is used in the most severe cases, and it's the most powerful. Of course, everything has a caveat, and we're going to talk about that. Okay, let's look at anti-resorptive agents. Again, what does that mean? We are preventing bone from breaking down. That's how they work. Most commonly used medicine is bisphosphonates, and Fosamax is the best example. You've heard a lot about it. It's been around for a long time. It's a great medicine, and it's still first line. The treatment guideline recommendations in most patients with regular osteoporosis, the recommendation will be to just take Fosamax. There's many reasons for that. But it's not the only medicine in its category. There's at least 3 others. You may have heard of Actonel, Boniva, and Reclast. Reclast is the IV form of bisphosphonate, and it's given in the office. So it's a very nice medicine to use if you just don't tolerate the pill. If you have problems with it, it can be given IV. And, the important question of all these medicines is, well, do they reduce fractures? That's why we're taking them. Do they actually reduce fractures? The answer is yes. Studies have shown that they really lower the relative risk of hip and spine fractures quite effectively. And that's why they're used. Okay, how about the caveats? Well, there's always a but. So what's the problem with the Fosamax? Well, really the most common problem is GI. It has to be taken a certain way. Your pharmacist will tell you or will tell you. If you're taking Fosamax, it really has to be taken first thing in the morning on an empty stomach. And you have to sit upright for a half an hour after you take it and not eat or drink anything else other than water. And that's because it has to be absorbed, and you want to prevent it from being refluxed up to the esophagus, because it can cause a lot of esophageal irritation and stomach irritation. So people who already have esophageal reflux or ulcer disease, they should not be taking this medicine. So another reason you may not want to take is if you have a kidney condition, if you have a chronic kidney disease, it's broken down by the kidney, so you don't want to give it in that situation. I'm just going to mention real briefly here, because it comes up a lot, that a very rare side effect of Fosamax or of all of the osteoporosis medications, in fact, is something called osteonecrosis of the jaw or atypical femoral fractures. Now, these are exceedingly, exceedingly rare. I mean, we're talking, something like 0.9 per 100,000 patients will get this, just to give you a sense of the rarity of it. But what is osteonecrosis of the jaw? It's a condition in which usually after dental work, if there's surgery that occurred in the jaw or involving the jaw, people can sometimes develop ulcers that don't heal. That can be treated and dealt with, but it's obviously a serious problem we want to avoid. Atypical femoral fractures are like hip fractures that happen spontaneously in patients who are on osteoporosis medicines. Now, of course, if you were to read this and Google it, you'd get very concerned and you'd say, you know what, not for me. I'm not taking any of these medicines, but they are exceedingly, exceedingly rare. I just kind of wanted to demonstrate that here in this picture. The take-home message is this: they are so rare, and on the other hand, having fractures from osteoporosis is so common that the risk of getting a fracture because you're not on medicine when you should be is much, much higher, much, much higher than the risk of getting one of these kind of very rare complications. So that's kind of demonstrated here. If you look at 1,000, look at the left side, you see 1,000 patients, you follow them over 10 years. In those patients who have osteoporosis but are not getting therapy, this is the number of fractures you'll see, just visually, okay? Now, if you compare them to patients who did get therapy over 10 years, similar number, look at the incidence of osteonecrosis of the jaw, atypical fracture. It's really so much proportionately less, so it's always a risk and benefit ratio. It's always something you have to decide and discuss, with the doctor, with yourself, with the family, but we still strongly believe that unless there's an exceptional case, therapy is still recommended. Okay, let's move on. That's Fosamax. Now, how about Prolia? So Prolia, you may have heard of, you may have seen it mentioned in the doctor's offices. It's an injection. So again, those patients who can't tolerate Fosamax because of GI stuff, or those patients who can't take Fosamax because of kidney issues, Prolia is what's offered next. It works in the same way. It prevents bone from being broken down, and it's given once every 6 months as an injection. Turns out Prolia is very powerful. Prolia is actually superior to Fosamax. So if you're someone who has more severe osteoporosis, more advanced, and you want to build up the bone more effectively and more quickly, you use Prolia because it really, really works. Here's an example. It's a demonstration. This is what happens to the change in bone density over time. The top blue line is Prolia. The green line is reclast, which is like Fosamax, but it's the IV form, and the orange line is Fosamax. So you can see that Prolia is superior to the other medicines in building up bone. But I want you to notice something else about it, which is kind of interesting. Okay, look what happens after year 3. Look what happens to the orange line and to the green line after year 3. You see that the bone density levels off. That's what happens with the bisphosphonates like alendronate, like Fosamax, that after a while, it no longer builds up bone, it just plateaus. But look at Prolia. Prolia is not only superior, but it continues building up bone over time. So that's why we really do like it as an option when it's the appropriate option. However, what are the caveats? What are the buts? What are the ifs, ands, and buts of Prolia? Yes, it can cause aches. That's rare. That tends to go away after a week or so. Yes, like all of them, I said, it has a very rare incidence of osteonecrosis and femoral fractures. But here's the main problem with Prolia that they found. This actually came to attention at the time of COVID. Okay, so if you remember what happened during COVID, people were staying out of the doctor's office. Of course, right? We were doing virtual visits. Everyone was in their home, and they were not coming to their Prolia appointments. And because it was in a doctor's office. And what was noticed is that very quickly after stopping Prolia, if you don't go to your next injection and some months pass by, the bone density goes way down. It plummets. It's almost as if you never were on it. So the effect really drops. Not only that, that was actually associated with increased fractures too. So it had implications. So the message is with Prolia, you have to be careful to always continue to receive your injection on time. You don't want to let anything pass. You don't want to miss it. You usually have like a month leeway, but after a month, it's like a light switch comes off and the effect is reversed. Now, let's say you want to stop Prolia. Let's say it's not you're having a side effect, or you don't want to be on it anymore, or whatever the case may be. No problem. That just transition. So it's fine. You don't have to stay on Prolia forever, but you have to be on something to keep the bone density up, because otherwise it just drops too quickly. That's the one of the newer findings I wanted to bring up about Prolia. Here you kind of see it demonstrated, okay? If you look at the top red line, that's Prolia, looked at over a course of 48 months. The yellow line is Fosamax, okay? So at month 24, where the dotted line is, they stopped giving Prolia to these patients, and you see that the bone density started plummeting. Notice what happened to Fosamax, right? The yellow line, Fosamax, just stayed the same. It gets to where it needs to go, and it plateaus, which is kind of steady. But not so with Prolia. Prolia will drop, and then when you give it again, the bone density starts rising again, okay? So that's the point I wanted to make about Prolia. Now, for this reason, okay, because Prolia has that bad habit of really causing a reversal if you don't continue it regularly, it's not usually offered as first line. If you look at the treatment guidelines for osteoporosis, Fosamax comes before Prolia, even though Prolia is more powerful than Fosamax, because we don't want to get into a situation sometimes where we're just tied to it indefinitely. We can talk more about that later. Nevertheless, having said that, because it's so powerful, if you have someone who just really has severe osteoporosis and they need to ramp up quickly, we will offer Prolia because it's so good. Okay, we talked about the anti-resorptives. We talked about the medicines that prevent breakdown. Now let's look at the other mechanism of action, medicines that build up bone. Okay, so this is Forteo. Forteo, interestingly, is a form of PTH, parathyroid. So the relationship between parathyroid hormone and osteoporosis is really interesting. Hyperparathyroidism is something that causes osteoporosis, but they were able to manipulate the parathyroid hormone in a way that it can actually do the opposite. It kind of mimics parathyroid hormone, but actually activates bone formation by stimulating osteoblasts. Now, Forteo is very unique in that it's given as a daily injection. So some people don't love that. Of course, you have to give yourself a shot every day. It's usually given over the course of 2 years. The thing about it is, however, because it doesn't just prevent bone loss, but causes bone formation and creation, it's really very effective and very powerful. Okay, it's far superior to Fosamax. So in the same way that Prolia has an edge over Fosamax, Forteo also has a significant edge over Fosamax because it's causing you to build bone. You can kind of see it demonstrated here, changes in bone density. Look at the top blue line, which is Forteo, versus the red line, which is Fosamax. Here's like a pictorial demonstration of what it does. So if you remember the pictures I showed you in the beginning, what normal bone looks like, what osteoporosis, porotic bone looks like, it's very empty and the fibers have dissipated. And here's what happens over time with Prolia. This was the osteoporotic bone on the left. This is, I don't mean Prolia if I said that, I meant Forteo. Here's what happens with Forteo. You see that there's now increased density of fiber in the middle of the bone and increased cortical bone. So it really is effective. Well, what are the caveats? Not that many, believe it or not. There was a concern in the original studies, animal studies of Forteo, where they saw an increased risk of osteosarcoma, but you don't really see that in human studies. So people are much less concerned about it. Forteo is an expensive medicine. It's a biologic, so it's hard to get. Depending on your insurance, but usually we can go to bat and then often get it approved. Forteo is a little bit similar to Prolia in that after you stop it, you must continue. You must follow something else so that you don't lose the bone that you gained. Okay, how about the newest kid on the block? The newest kid on the block, which is Evenity. And Evenity works as both a bone builder and something that stops bone breakdown. As I said before, Evenity is the king of the hill, so it's number one. It's Elvis, it just it's really the very best, and that can be demonstrated. They actually compared Evenity to Forteo and to Fosamax, and you see that the top line here represents a Forteo. It's a green, rather Evenity. It's the top line. So the reason why it's so good, they think, is because this is one that does both, as we said. Both builds up and prevents breakdown. It's given, I'll just mention, it's given as a once monthly injection for 12 months. You can only get it for a year at this point. You come in once a month. Does it have side effects? Mild and minimal. What some people describe are headaches and joint aches after getting it. It's brief. The main concern with Evenity is the following. When they did the original comparison studies to agents like Fosamax, they did see a slightly higher incidence of cardiovascular events, stroke and MI. And so that's why you do have to be careful with it. The current recommendation on this medicine is not to give it if anyone has had a cardiac event in the past year. But technically speaking, if you had a cardiac event, let's say 3 years ago or 5 years ago, you could get it. They think it's only within the first year. When they analyzed the patients who had problems, they were people who had it within that time. If you've had it in the distant past, you could get it. But look, it is a case-by-case decision. It has to be discussed. If you have ongoing active cardiac risk factors, high blood pressure, high cholesterol that's not adequately controlled, perhaps diabetes that's not adequately controlled, you wouldn't necessarily give it. But if none of this applies to you, and if you have the right kind of osteoporosis, quote unquote, it's definitely a very potent treatment recommendation. I just want to mention briefly, there's yet more medicines that are used for osteoporosis. There's a medicine called raloxifene, which is sort of it's estrogen-like in that it acts like estrogen at the level of the bone, and therefore it helps prevent bone loss the same way, as hormone replacement therapy. But also, it's supposed to be very helpful for patients who are at risk for breast cancer because it blocks estrogen at the level of the breast tissue. So sometimes you have somebody who's, sort of like just after menopause and maybe at high risk for breast cancer for whatever reason, they use these medicines, because they help build up the bone in such a case. Then there's hormone replacement therapy. Now, hormone replacement therapy has gotten a bad rap because the Women's Health Study Initiative, which was done 20 years ago or more, did show complications, cardiovascular complications in patients who received hormone replacement therapy. However, if you have someone who is of the just postmenopausal age, who does have advanced osteoporosis and has very severe menopausal symptoms, sometimes you'll give a hormone replacement therapy just for a brief period, and it will help the menopausal symptoms. It'll also help build up the bone. So these are, not commonly used, but there are certain there are certain places for them. Okay, so to summarize, okay, treating osteoporosis. We have a lot of great treatment options. How do we know what to use for which condition and for which patient? So, at a very basic level, we now divide patients up into high risk or very high risk. And that has an implication for how to treat it. High risk, I would call regular osteoporosis, as we defined it a couple of times tonight. T-score 2.5, or osteopenia with fracs, or just regular solitary fracture. That's high risk. Very high risk, though, is T-score less than 3. If you're someone who has a T-score of minus 3.5, that puts you in the very high risk category for fracture, or less than minus 2.5 with fragility fractures. Another category is multiple vertebral fractures. So people who are in this category have a higher risk of fracture. We call them very high risk. So what difference does that make with regard to treatment? It's the following. If you're high risk, meaning regular osteoporosis, we recommend Fosamax or bisphosphonates first. If it's slightly more advanced, we might recommend Prolia. The anabolic or bone building agents that we talked about, Forteo and Evenity, the injection medicines, they're a little fancier, a little more high stakes. They're used in the very high risk patients, and they're very effective for them. So that's kind of how we view things broadly. Sequence matters. The order matters. So what you give in what order, this is something that's being studied a lot, very intensely. Just remember that if you do get one of the bone building medicines like Forteo and Evenity, you always have to follow it up by another medicine, because you can lose your gains very quickly, just like we said for Prolia. Prolia should always be followed up by a bisphosphonate or something like alendronate, but the other medicines should too. Okay, so, once you have osteoporosis and let's say you're being treated, how do we monitor? We monitor mostly with bone density studies. It could be every year to get another bone density if you're already on active therapy, or every 2 years if your case is very mild. When do you change therapy? It's kind of what you would expect. If the bone density is decreasing or getting worse despite your therapy, you may change therapy. Obviously, if a new fracture develops, that means the therapy is not quite working. You want to make sure you're taking it correctly. You want to make sure you're not having side effects that are interfering with it. There's something else out there called bone turnover markers. These are blood tests that people sometimes measure that they tell you whether the bone is being resorbed. The higher the number, the more the bone is being resorbed and the more active the osteoporosis is. So the best example of this is something called CTX. You guys may have heard of a blood test called CTX. They're trying more and more to use that, because it would be kind of nice if we can use that as a marker of how we're doing. Remember, what's the problem with bone density? Problem with bone density study is that you can only do it every year or every 2 years. Well, what if you want to know how you're doing after 3 months? What if you're concerned? So people are starting to use this test, and it's helpful in some people. We still have to iron it out, but the CTX test is kind of something that's entering prime time. How long should you be on these medicines? That's another question everybody asks. We don't know the exact answer. A lot of it has to be taken case by case, depending on what happens. With the Fosamax, bisphosphonates, there's something called a drug holiday. So after you've been on it for 3 to 5 years, we generally stop. We stop for at least 2 years, because if you're on it for too long, too many years in a row, you increase your risk of some of those rare side effects that we talked about. But the other reason why we stop is because it stays there. You may remember that graph that shows that Fosamax plateaus. It stays in your bones usually for a good 1 to 2 years and continues to work even after you stop it. So that's why we generally stop after 5 years, see what's going on, and then if the bone density has declined, we go back to them. All the injection medicines that we spoke about, the bone builders, Forteo, Evenity, we always stopped after a year or 2 years, and then we quickly followed up with something else. Remember what we said about Prolia. always make it on time to your Prolia injection, or if you know you're going to stop, then we need a game plan for something to pick it up after. People ask about Prolia. Well, okay, we know you told us that, we shouldn't miss our next injection. We don't want things to, we don't want to lose the effect, but does that mean I have to be on it forever? 20 years, 30 years, forever? Well, the answer is not necessarily. That's why we follow the bone density. And what happens over time is eventually the bone density really improves. And if it improves to the point where you're no longer in osteoporosis, sometimes we say, okay, you know what, let's stop, watch carefully, and then see what happens. So you're not necessarily confined to it indefinitely. Okay, what are our take-home points? Osteoporosis is highly prevalent. It's really a major public health issue, on par with cholesterol and hypertension, as we showed you. Osteoporosis leads to fractures, unfortunately, very, very common. And don't forget that if you know someone who's had a fracture, they should be evaluated for osteoporosis. They shouldn't just get that surgery or just get that cast and then just to walk along their merry way. They should have an evaluation, and they may need therapy that will prevent it from happening again. So it's essentially to diagnose and risk assess for osteoporosis. Remember, lifestyle modification is huge. If you exercise regularly, you eat a healthy diet, you get your calcium and vitamin D in, that can really help you and help prevent further bone loss. And know that there's a whole bunch of terrific medicines out there that can really, really be helpful depending on your situation. And with this, we can prevent fractures. I'm just going to show you a slide. This is a patient who was told that she was diagnosed with osteoporosis, and she was told, you know what, she said, well, can I do anything about it? I mean, what's going on here? And they said, well, yeah, you should be on medicine. Unfortunately, osteoporosis just progresses. But yeah, some people do exercise. And she's like, okay, what kind of exercise? And they said, well, how about weight bearing? She says, okay, I'm there. I'm going to do the weight bearing. So she took up weightlifting, and she became the champion in her age category for weightlifting. And this is someone with osteoporosis. So you can do terrific with osteoporosis with the right approach and treatment. And this is an example. So thank you very much.